Hello, everybody, and welcome to this discussion on the introduction to heart failure. My name is Tom Fusillo. I'm an internal medicine resident physician. In this talk, I'm going to talk about the fundamentals of heart failure, and that includes how to recognize it, the types of heart failure, and really the pathogenesis of how this disease plays out. Especially if you go into internal medicine, you're going to be seeing this a lot, particularly in the inpatient setting. So it's a really important disease to know a little bit about. Importantly, we're not going to talk about treatment specifically in this video because that's just a huge topic that I'll talk about in its own video. But with that, I hope you enjoy. All right, so let's get started in talking about the fundamentals of heart failure. So the American College, Cardiology, American Heart Association, Heart Failure Society, they all define heart failure as a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or the ejection of blood, leading to cardinal manifestations of dyspnea, fatigue, and fluid retention. So important distinction here, it's either the impairment of ventricular filling or the ejection of blood. And you can have both too, one or the other or both. Let's talk a little bit about the epidemiology of heart failure. This is very common in the US, and worldwide for that matter. About 6.2 million patients are currently being treated for heart failure in the United States, with over 26 million cases worldwide. So this is a big problem that physicians all over the world are dealing with. Over 600,000 new cases diagnosed annually in the United States, and the prevalence increases with age. This is largely because you'll see many of the risk factors also increase in prevalence with age. Interestingly, the hospitalizations that are due to heart failure actually decreased from 2006 to 2016. And one of the theories is we're actually getting a lot better at treating heart failure and we're catching it earlier. And when we catch it earlier, we've gotten better at preventing it from progression. So that's possibly why these hospitalizations have decreased. It's most common in African Americans, then Hispanics, and then whites. One of the most striking statistics here is that the 5-year survival is about 50%. So when you really think about that, that's worse than a lot of cancers. So this is a serious diagnosis that we really need to try our best to catch early, to treat aggressively, and to really emphasize to our patients how important this is to stay on top of their medications and to stay on top of their appointments. It contributes to 1 in 8 deaths, so just harping on that point that this is a disease with a lot of mortality, and it has a greater incidence in men. And so if we look, this is a heat map of death due to heart failure in the United States. So very prevalent along the southern US, in Texas, Oklahoma, Arkansas, Louisiana a bit, coming up here, sort of into Appalachia, but that's just the general pattern here. Some of the causes and risk factors of heart failure. So I like to look at these in terms of modifiable and non-modifiable risk factors. So what does that mean is non-modifiable risk factors are things you just can't help. So you can't help getting older. You can't help your genes. You can't help your sex. Things that are modifiable, well, if you smoke, you can stop smoking. So that's modifiable. Your blood pressure, you can modify that with diet, exercise, medication, cholesterol, that type of thing. All modifiable risk factors. Coronary artery disease, or CAD, causes about 66% of heart failure cases. So this is a major cause and contributor of heart failure. And this is in line with an ischemic cardiomyopathy. Hypertension contributes to about 3/4 of cases. So that's what you might hear of hypertensive heart disease. That's a major contributor. Diabetes is a contributor in 10 to 40% of cases. And then there's congenital heart diseases, which we don't see too often, but we will see these patients from time to time. We have the inherited cardiomyopathy. So think this is something like hypertrophic obstructive cardiomyopathy and arrhythmogenic cardiomyopathies like tachycardia-based. We then have systemic diseases. These are things like amyloidosis, especially ATTR amyloid, sarcoid, and lupus. And there's drug toxicities. This is more common in the chemotherapy area, especially your anthracyclines. Infections can also do this. So these are infections like HIV and Chagas disease. And finally, rheumatic heart disease continues to be a cause. It's less common in the US because you don't see that as much here. But there's many patients here that may have come from other countries where it is still prevalent. All right, so let's talk about the subtypes of heart failure. So the subtypes are really based on the ejection fraction. And so there's 4 types. The main 2 are HFrEF, which is heart failure with reduced ejection fraction, and HFpEF, or heart failure with preserved ejection fraction. And there's kind of other subtypes down here, which is HFmrEF, if you want to say it that way, which is heart failure with mildly reduced ejection fraction, and then HFIMPEF, heart failure with improved ejection fraction. So we'll start up top. Each of these are about 50% of patients, so half and half roughly. And we define these, as the name implies, by ejection fraction. So in HFrEF, or reduced ejection fraction, the ejection fraction is equal to or less than 40%. In preserved, it is greater than or equal to 50%. And so you're saying, well, it's between 40 and 50. Well, that's the mildly reduced, or heart failure with mildly reduced EF. So between 40 and 50%, you have HFmrEF. And then finally, if you have a patient who was HFrEF over here, so they had an EF that was less than 40%, but it's improved over time and now it's normal, this is considered heart failure with improved ejection fraction. So we used to use the terms systolic and diastolic. Systolic heart failure, largely in line with heart failure with reduced ejection fraction. Diastolic, largely in line with HFpEF. And this is mainly because if you think about it, when your reduced EF is there, you're not squeezing. So that's generally a problem in systole. On the other hand, if your EF is preserved, the problem really is that the ventricle is not relaxing properly, which is occurring in diastole. So that's why these names you might see sometimes, but we've really strayed away from that because there are many patients now that can have a little bit of both. They may not squeeze as well, and they may not relax as well too. So it can get a little confusing. And so these two down here, they're both really treated similar to HFrEF. Mildly reduced, we're starting to treat similar to HFrEF. And then generally speaking, if you have somebody who is reduced EF and it improves, we continue to treat them as if the EF is still reduced. So we'll talk about the pathophysiology here. This is really important. So first, there's an initial event and subsequent remodeling of the heart muscle. So in an acquired heart failure, there's usually a triggering event. Many times, this is an MI, myocardial infarction, or some sort of long cardiac ischemia, or very chronic hypertension. Right? So the longer you have very high blood pressure or chronic hypertension, that's more force that the heart has to pump against. So you're really doing a number on that muscle. If you think about it, the normal heart rate is about 80 beats per minute. We have 60 minutes an hour, 24 hours a day, 365 days a year. How many years you're going to live for? 80 years. So that is a ton of work the heart's doing. It's constantly going. If we look at here, so how does this happen? Like we said, you have a high workload initially. So this is something like hypertension, or you have ischemia, and that leads to a myocardial oxygen supply-demand mismatch. So what do I mean by this? The muscle requires more oxygen than it's actually getting. So if it's working so hard, that means it requires more than it's getting. And if it's ischemic, the oxygen's not coming in that it needs, right? Because there's ischemia. The vessel is cut off. And you have that, you get myocyte hypertrophy as a compensation method. And then after that, you start to get interstitial fibrosis and fibrosis depositing in the myocardium itself. And that's just what this is showing here, all these same concepts. An absolutely crucial part of this pathogenesis is the sympathetic response with catecholamines and the renin-angiotensin-aldosterone system, or RAAS. So if we start looking over here in the heart, you get an initial decrease in cardiac output from the changes in the muscle, right? And with that, you start to get baroreceptor dysfunction, where you have baroreceptors in the aortic arch, carotid sinus, that type of thing. And when you start to get the low output, these baroreceptors are having different functions and they're malfunctioning. After that, these relay to your nervous system and you get the sympathetic response to try and fix what's going on here, because your body thinks that, oh, okay, the heart's not pumping well enough. Not enough blood is going forward and being pushed out into the circulation. So we need a sympathetic response to get that going. And so this is in the neurohormonal area. And so two things happen. In the pituitary, ADH, or antidiuretic hormone, also known as vasopressin, is secreted. The other thing is your catecholamines are released. So if we look down here first at ADH secretion, we know ADH goes to the kidneys, and what does it do? It tells them resorb more water because we're trying to increase blood pressure. We're trying to raise the intravascular volume because that's the body thinks we're volume down and that we're soft on blood pressure. It also has a direct impact on vasoconstriction. So in the ICU, sometimes we use vasopressin as a vasopressor in patients that are in shock because it raises blood pressure by vasoconstriction. Okay, so you have these areas with ADH, and up here with the catecholamine release, this also goes down to the kidneys where renin is released and the RAAS system starts to ramp up. As we know, renin goes to angiotensin, then aldosterone. And what these things do is they have the effect of decreasing the renal blood flow by clamping down on those intrarenal vessels. And that matters because where sodium goes, water goes. So increase in sodium reabsorption is going to lead to increased water reabsorption as well. We're already getting some down here from the ADH. And then also a direct vasoconstriction effect. So some additional players here. Endothelin contributes primarily to the pulmonary vasoconstriction and direct cardiac inflammation and hypertrophy. But so far, research has shown that endothelin blockade hasn't really benefited in left-sided heart failure, but it is helpful in pulmonary hypertension. We're also starting to learn that heart failure is an inflammatory condition. As we start to see these inflammatory cytokines, things like IL-1, TNF-alpha, and with that, the actual impact of sorts of anti-inflammatory therapy remains mostly unknown, but that's an interesting area of research in heart failure right now. And then finally, there's reactive oxygen species that are created in this process. So the body does have counteracting hormones that try and work against all these things that are going against us. These include things like ANP and BNP. So what those stands for is atrial natriuretic peptide and brain natriuretic peptide. ANP, or atrial natriuretic peptide, is secreted in the atria, like it sounds. And BNP, don't ask me why it's called brain natriuretic peptide, but it is released in the ventricles. And as they sound, these cause natriuresis. They communicate with the kidneys and have a diuretic effect to try and lower that volume because we're usually in a hypervolemic state when we're in a cardiac heart failure overload and decompensated state. Over here, what we're looking at is just the biochemical pathway of BNP. I showed BNP here because this is the one we usually measure clinically. Importantly, these are inactivated by something called neprilysin, and that's important because when we learn about the pharmacology and how we treat heart failure, there's some medications that will block neprilysin, therefore allowing ANP and BNP to continue to do their job. Prostaglandins also play a role, and nitric oxide. They both increase the systemic and pulmonary vasodilation. Let's talk a little bit about the EP, or electrophysiology, in heart failure. So as you can imagine, as your cardiac muscle is starting to hypertrophy, it's going to start to prolong the QRS. So the thicker that muscle gets, the worse electricity is going to conduct through it. So you start to see this prolonging the QRS. Then when it gets long enough, you have a left bundle branch block. So that's what we're seeing here, right? That kind of RS, R classic in the left precordial leads. In patients with AFib, you can also have more RVR, or rapid ventricular response, as well as increased PVCs, or premature ventricular contractions. So it wouldn't be a heart failure lesson if we didn't talk a little bit about hemodynamics and decompensation. There's going to be a different video on this in particular because this is a big topic in itself, but I want to touch on it a little bit here. So when we're in a state of decreased cardiac output, it's going to lead to fluid retention because blood flow is not circulating. 25% of our cardiac output goes to the kidneys. So if the kidneys are not getting blood, they can't filter anything out into the urine, so you retain fluid. So a high fluid or hypervolemic state is going to overstretch the LV, or the left ventricle, via an increased preload. So all preload is the pressure put on the left ventricle at maximum filling. So left ventricular end diastolic pressure is another way to say what preload is. And if you can think about it, an overstretched LV can't eject as much blood as a decreased stroke volume. Initially, you may think, if it's overstretched and there's more blood in there to begin with, why is it having trouble ejecting as much? Two analogies I always think of that help me understand this is, imagine you're doing push-ups, right? If you're doing a push-up and your arms are 90 degrees in front of you, they're right in front of you, you can do the push-up fairly easily. Okay, so now imagine you're doing a push-up, but your arms are way out to the sides in front of you. It's way, way harder to actually do that push-up because your muscles are stretched out. The other one I can think of that helps me understand is bladder contractions, actually. Sometimes a patient might have a bladder that is so overfilled, it's so overstretched with urine, that it actually is harder for them to urinate spontaneously. It's harder for the bladder to contract because it's so overstretched. That might be even like a better comparison, really, because we're talking about fluid in a muscle contracting around it. So if we look at some graphs and charts to try and represent it, these are what's called the Frank-Starling curves, which are crucial in learning the pathophysiology of cardiology in general, but especially in heart failure and decompensated heart failure. So what we're looking here on the left, so the y-axis is stroke volume, the volume of blood being pushed out with each beat, and on the bottom is the preload. So left ventricular end diastolic volume. It's in volume instead of pressure here, but the concept is the same. In the normal ventricle, you can see as the left ventricular end diastolic volume increases, there's an increase in stroke volume. In a heart failure patient that is compensated, you have a slightly reduced stroke volume, but it's compensated, all things considered, with sympathetic compensation. And you also have a slightly increased end diastolic volume because remember, we said the preload is usually high, which overstretches the LV. And then this bottom line here is showing, well, if you're in decompensated heart failure, you're not having any sympathetic compensation, it's going to be even worse, right? You're going to have even lower stroke volume, and this is just a cycle that worsens everything. On the right, it's the same kind of thing here. And what this is showing is actually when you get to a maximum point, the stroke volume starts to tip down. So as you get to a point where there's more and more preload, your stroke volume is going to start to go down because your LV is so overstretched. All right, let's talk about the initial exam here. Starting with the history, shortness of breath is key, right? Why is it key? Because a lot of times in heart failure, and especially exacerbations, you're going to get pulmonary congestion because the blood is backing up into the lungs because the LV is not pumping it out into the systemic circulation. That's pulmonary congestion or pulmonary edema. And in your patient, you're going to be talking to them, they're going to say that they have shortness of breath when they do work or they get up or they do something. If it's even worse, they might have shortness of breath at rest. But what's really key here is orthopnea, which is shortness of breath when you lay flat. So a lot of times you can tease this out. You can ask, how do you sleep at night? And you'll be surprised. Sometimes they'll say, I actually sleep in the recliner because when they lay flat, they get so short of breath. Or if they do sleep in bed, you can ask, how many pillows do you use? If they're using 2-3 pillows, that could be a sign of orthopnea. Cardiac cough is something that can happen as well. Because of that fluid backup, it can cause inflammation in the bronchial airways. Lower extremity swelling edema, simply because of a hypervolemic state. You just have so much fluid and it's pooling into the venous and the third spacing or the interstitium in the tissues. Fatigue, weakness. And another thing, just ask what kind of physical activity can you do? Are they living their normal life or is this restricting what they do? Are they having trouble doing the work they used to do? What are they doing around the house? That type of thing. And that can be particularly important because of what's called the New York Heart Association staging or NYHA stage. And this is a functional stage. It can be used to track the functional progression of the disease. So it's stages 1 through 4. Stage 1, you essentially have a completely normal patient. They might have heart failure, but it's not inhibiting any of their activities. They go around their day and they have no problems. Stage 2 is when you start to see limitations, right? They're comfortable at rest. They can do some regular chores around the house. But if they start to do anything heavy, maybe yard work or things like that, they're going to start to get symptoms. They may have to take breaks. They may not be able to do it. When we get to stage 3, it's much more significant than stage 2. So they are usually comfortable at rest, but even with the regular things around the house, standing up, cleaning the dishes, showering, things like that, they're going to get short of breath. They're going to start having symptoms of heart failure. And then finally, stage 4, these people have symptoms at rest usually. And a lot of times they're even bedbound because any movement or any sort of physical activity, they're just going to get out of breath and they're going to get into a more decompensated state. On physical exam, so first things first, look at the vital signs. Is your patient tachycardic? Are they hypertensive? Remember, longstanding hypertension is a risk factor for heart failure. But I'll also say the presentation here can be highly variable, especially if this is a patient that's presenting earlier in the heart failure pathogenesis. Look at their neck. Do they have jugular venous distension or JVD, which is what this gentleman here is showing you? This is tested by having your patient turn their head to a side. And then if you have them on the stretcher, put their head or the head of the bed at 45 degrees and look for that jugular vein if it's pulsating out. You can measure this. It's technically measured from the sternal angle. So you measure and you see how high up it is in centimeters. And there's even an equation that you can assess the jugular venous pressure by using how high off the sternal angle it is. There's also the hepatojugular reflex. You need to apply pressure to the right upper quadrant over the liver and the abdomen, apply it constantly for 15 to 30 seconds, and then look at the jugular vein. And if you have something pop up like this that wasn't there before, that is a positive hepatojugular reflex. Of course, we're going to do a heart exam, heart auscultation. Remember, in heart failure, the muscle has hypertrophy. So you might actually have a displaced point of maximal impulse, or PMI. Usually, so you can imagine this gentleman's rest of his body here. If it's normally here, it might migrate laterally because the heart muscle is so much bigger now. And you can also hear an S3 gallop, which is usually a sign of overload and noncompliance. Lungs, if this patient has pulmonary edema, you could hear rails or crackles. Looking at their abdomen, do they have hepatomegaly? If heart failure gets so bad, it can start to back up to the level of the liver, and they can get hepatomegaly. And then a really important one, look at their legs. In their extremities, do they have edema? And is it pitting? If you have pitting edema, that means you have fluid in the interstitial tissues, like you can see here. So you just press your finger into their shins, their pretibial area of their shins, leave it there for a few seconds, then take your finger off. If you have a pit like this, that's pitting edema. Additionally, these people can have clubbing in the fingers, decreased capillary refill because their circulation is just poor because their heart's not pumping as effectively. And another thing I'll mention with edema and pitting edema is if it goes up to the level of the waist, that's now called anasarca. So we'll talk about the workup here. When it comes to lab testing, of course, we're going to have CBC. Anemia is important to look at in these patients because it's a negative predictor, and it can also actually contribute to the pathogenesis of heart failure. If you imagine, if you have lower blood volume, your heart is going to need to pump more blood in the same amount of time to try and make up for that, right? Because oxygen is in blood. If you have less blood, then you're going to have less oxygen, right? So the heart tries to compensate by pumping more effectively. But over time, that's going to lead to hypertrophy of the muscle, and it can help with the pathogenesis of heart failure. If they are anemic, get iron studies. There are a lot of studies now that show that repleting iron in iron-deficient heart failure patients is beneficial. Always get a metabolic panel. Complete is better than basic, because a lot of times if you're retaining fluid, you can have electrolyte imbalances, hyponatremia, renal disease, AKIs, chronic kidney disease, that type of thing. Get a UA. This also helps assess the renal function, especially looking at the protein, if there's proteinuria. And then some of the comorbidities. So a lot of these people, like we mentioned, have diabetes, so get an A1C, a lipid panel for cholesterol, because we know that can contribute to coronary artery disease, and a TSH. Some thyroid states can contribute to heart failure pathogenesis. And like we mentioned earlier, the BNP is really important. You can also get this pro-BNP. It's important to know that these can be falsely low in obesity, right? And so what we're looking for in the BNP and pro-BNP is if these are high, that means your heart is secreting it because it thinks it needs natriuresis, right? It thinks it's in an overload state, so that is often a sign of heart failure. We really should always be getting a chest x-ray if we're concerned about heart failure, especially in the inpatient setting, because it's just so easy to get. It's cheap. You can get a lot of information. So we're looking at cardiomegaly, cephalization of the vessels, pulmonary edema, pleural effusion, Curly B lines, and the batwing sign. So let's look at a chest x-ray to go over these. Cardiomegaly. So first of all, what is the actual criteria for cardiomegaly? So cardiomegaly is if your heart borders are greater than half of the chest. So what do I mean by that? From the ribs out here to the midline, if you were to take this heart, transpose it over, and it's greater than that, you have cardiomegaly. So in this case, definitely is cardiomegaly because this distance is longer than this distance, okay? Cephalization of vessels is when you start to see some vessels and edema going up towards the head, cephalad, right? So you can see here, this patient does have that, right? Here's one up here. You can see things start to come out above. Pulmonary edema clearly is in this. This is very edematous, very pulmonary edema. You have this very fluffy look coming out from the hilum, right? Because all your vessels start in the hilum. You're going to see that. And that relates to the batwing sign as well. The batwing sign is supposed to be, you can trace out a batwing on the hilum a bit. Like many things in medicine, it doesn't really look like that, but that's just what it's called, the sign. And then curly B lines. It's hard to see this because it's a bit of a zoomed out. You can't zoom in here. But curly B lines is when you have vessels that you see go all the way to the edge of the chest. So things are so congested, they're congested all the way out to the periphery. So that would be a curly B line. What's crucial in heart failure is getting an echocardiogram, which is a dynamic video, essentially, of heart and its function. So this is one that I actually took myself. It was a patient I saw, and I just didn't really have a good feeling. I thought there was something else going on. So I just took the ultrasound, put the probe on his chest, and look at the heart. And so what we're looking at here is the left ventricle. You can see over top, this is the right ventricle. You have the left atrium with the mitral valve coming into the LV, and then it's going to pump out the LVOT, or the left ventricular outflow tract, over here. And so what we're looking at is how well is this left ventricle squeezing? And as you can see, and this sometimes takes practice at looking at, every time it goes into systole, which is when it's pumping blood out, really not squeezing very much, right? You can see the black space, which is blood in the ventricle, isn't really getting smaller when it squeezes. So I ended up calling cardiology. They reviewed this and they said, yeah, there's probably is an ejection fraction around 30 to 35%. So this would be heart failure with reduced ejection fraction. So look at this a bit, try and get used to what this could look like, and that'll help you a lot, especially if you're able to do POCUS or point of care ultrasound. Finally, additional imaging modalities. There's cardiac MRI, which we use a lot of times more if we have one of the congenital cardiomyopathies or systemic illness like ATTR amyloid. These can be helpful. But some people also, they'll have machinery or devices inside them that can't get an MRI because of the magnetic field. There's also cardiac CT and cardiac PET scans. So this is a cardiac CT, but you can also get cardiac PET scans as well. So that was a little bit about heart failure. Hope you learned a few things about the pathogenesis, how to recognize and work up this disease, and hope to see you in the next video. Remember, videos coming out on the treatment of HFrEF and HFpEF.